we'll go ahead and get started. So welcome everyone. My name is Mina Nabavi, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm excited to welcome you today to today's webinar. Yes, having a robust hand hygiene program is still important, featuring Mary Duncan, Senior Director of Infection Prevention with the University of Alabama Birmingham Health System. This is the second webinar that is part of our webinar series focused on multi-drug resistant organisms, or MDROs. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control, Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past webinars and podcasts, sign up for our newsletter, request training and technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. You can also email arcipc@uab.edu. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety, and the Alabama's Statewide Area Health Education Centers, or AHEC. You can learn more about their programs on the centers as a whole at the websites listed on this screen. We'd also like to let you know about our next upcoming webinar with AC Burke, Beyond the Basics, Cleaning and Disinfection to Mitigate the Spread of Infectious Diseases, including MDROs for Healthcare Facilities. This webinar will be the third in our MDRO webinar series. This webinar is designed to help the infection preventionists take their cleaning and disinfection program to the next level. Efficient and effective evaluation of cleaning and disinfection of patient and resident rooms and use of supplemental disinfection strategies can mitigate the potential impact of the healthcare environment on the spreading of infectious pathogens, including MDROs. Webinar participants will learn about the pros and cons of different methods for evaluation of cleaning and disinfection practices, impact of how disinfectants are applied to surfaces, and the pros and cons of supplemental strategies for enhancing disinfection. This webinar is presented by the Alabama Regional Center for Infection Prevention and Control and is co-sponsored by the Deep South Center for Occupational Health and Safety and the Alabama Statewide Area Health Education Centers. This webinar will be held on April 11th at 12 p.m. Central Standard Time, and you can register by scanning the QR code on your screen. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must 1. Register for the training, 2. Watch the entire program, and 3. Complete the evaluation following the program. Upon completion of the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you will also need to complete. For nurses in the state of Alabama watching this program live, CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. CE units for this program will expire on March 12, 2025. If you experience any issues, please email arcipc@uab.edu. We will place this email address in the chat box. And finally, it's my pleasure to introduce our speaker. Mary Duncan is an experienced certified infection preventionist who has spent the last 18 years implementing best practices at various facilities to prevent infections in patients. She is currently the Senior Director of Infection Prevention at the University of Alabama Birmingham Health System. This is over an 1,100-bed Level 1 trauma center in the city of Birmingham, Alabama. Through her passion and innovative approaches, she strives to decrease infections by working with frontline staff to make sure they are educated on best practices and have access to the tools they need to do the right thing. Mary is skilled in the ability to listen and identify issues or problem areas and form innovative solutions that increase the safety for both patients and staff. Welcome, Mary. I'm going to now pass things over to you.
Okay, well, good afternoon, and thank you for joining. I am so excited to be the second presenter for the MDRO series, which I think is such an important thing to have since MDROs are becoming more and more rampant across the country. So hopefully this will be able to give a little bit more importance on hand hygiene and give you some suggestions on how to create a good program. I also hope that you were able to join us last month to hear Kate Draper's presentation on multi-drug resistant organisms. So she really did a great job of laying the foundation on how organisms are spread within the healthcare system and how they develop resistance to our current treatment options. So in our lecture, she touched on the importance of hand hygiene to stop the spread of these organisms. And really, I mean, I'm sure all of us can agree that hand hygiene is the most important task that we could do to stop the spread of organisms. The question really becomes, how do we ensure that staff are performing hand hygiene effectively and at the appropriate times to really prevent the spread of the organisms? So when I was first approached to do this presentation on hand hygiene, I thought, absolutely, this will be so easy. However, when I started doing the research and putting the presentation together, I quickly remembered that hand hygiene is not easy. It's hard. And to get a good, effective program takes a lot of work and a lot of dedication. But on the other side of it, when you put in the work, it's very rewarding and does make a difference. So we know, as with everything in healthcare, it's multifactorial and complex. And what is going to work at one institution or a department or even a unit is not going to work everywhere. So my objective today really is to give you the tools to help you design a program that's going to work for your individual facility and helps to make hand hygiene part of your safety culture. So in order to do this, we're going to go over the importance of a hand hygiene program, look at some resources that are available to help you create this program, talk a little bit about types of hand hygiene audits and some auditing practices. And then in an effort to help you identify what might work in your facility, I'll give you some examples of what I've experienced in my career and some things that I've heard that other facilities have done as well. So first, we need to start with some facts to identify why we need a robust hand hygiene program. So based on numerous studies that have been done over the years, we know that microbes that cause infections are most frequently spread to patients on the hands of healthcare workers. We also know that these microbes can live on our hands for hours if they're not cleaned. And studies have shown that healthcare worker adherence to hand hygiene really hovers around 50 or 60%. Statistics show that about 1 in 25 patients acquire a healthcare-associated infection during their hospital care. And of these, about 80,000 deaths are going to occur annually due to these hospital-acquired infections. So why are hands so good at spreading pathogens? And it really boils down to their microbiome. So we know that there are both transient and resident flora on our hands. And the transient flora are the ones that are acquired during contact with our patients and our surfaces. They usually will colonize the superficial layers of the skin, which means that they're going to be easy to remove if we do hand hygiene appropriately. And these are going to represent the microorganisms that are most commonly associated with our healthcare-associated infections. So MRSA, VRE, Staph aureus, some of our other MDROs, usually are transient flora. On the flip side, we have a resident flora, and this is part of the person's microbiota. They colonize deeper layers of our skin, which makes it so that they're harder to remove with hand hygiene. But these organisms really are less likely to cause our infections. And basic examples of these are Staph epis. We also know that the environmental surfaces immediately around or near the patient can look clean, but they're often contaminated. And so as a result, people may not think about cleaning their hands after they're touching these surfaces. However, there are a lot of studies out there that show that this bacteria is present and it can be picked up on our hands and transferred to other sources or other patients. So what are the roles of hands in the transmission of pathogens? Well, as we said, healthcare workers are frequently touching the skin of the patients and potentially contaminated environmental surfaces near the patient, as well as their own body and clothes. In fact, there was a study in an intensive care unit where a staff member wore a head-mounted camera, and this showed that they had contact with the surface about once every 4.2 seconds. So this means that there's a lot of opportunity for healthcare workers to contaminate their hands with pathogens. But what it means more to me is that it might not be as intuitive as when healthcare workers should be doing hand hygiene. And this is where it really becomes important to walk through processes with the frontline staff and to think about when hand hygiene would have the greatest impact on preventing transmission to the patient. So when I was working at it as an infection preventionist at a children's hospital, we were having a high incidence of MRSA infections in our neonatal intensive care unit. And we couldn't figure out why, because our hand hygiene compliance really was high. And so we put a group together with frontline staff. We went into a patient room that was set up and had the nurse just go through her normal care from, doing the assessment, typing on the computer, giving meds, changing diapers, that type of stuff. And we quickly learned that there are a lot of hand hygiene opportunities. However, when we really drilled down, there were a few that would have the greatest impact on preventing transmission of pathogens. And so we took this information and created education around it so we could give nurses the power to know how best to protect their patients. So the ultimate purpose of hand hygiene is to remove microbes from hands so they cannot be transmitted to patients. So as we look at this picture, we probably all get the ick factor. And for whatever reason, people love this and respond to it. So since we can't see pathogens without a microscope, we need to get clever about helping people envision them. So at another facility that I worked at, we went into a patient's room and had someone touch different surfaces like the keyboard or the IV pump or the bed rail. And then they would put their hands on the agar plate. We sent that down to the micro and they incubated it for 24 hours. And then we went and we took pictures of what grew on the plates and then labeled it with whatever surface the person had touched. We didn't go as far as identifying the bacteria because really we just wanted staff to get a visual that they were picking up these pathogens when they were touching surfaces and that those pathogens could be transmitted to another surface. Another way that we've done this to show the potential for transmission is putting glow germ on a mannequin and then having the healthcare worker go in and do their standard of care and touch the IV poles and the monitors and the patient and everything. And then afterwards, we would go in with the black light and show that the glow germ was spread throughout the patient's room. So when I think about things that have been invented over the past decades to prevent infections, there are a few that really stand out as game changers to me. And what I mean by game changers is that they've saved millions of lives. And these products include vaccines, antibiotics, which really don't need any further explanation. The alcohol chlorhexidine to me was a game changer because it prevents so many vascular access device infections and surgical site infections. The disinfecting wipes were huge because it made it easy for anyone to disinfect surfaces around the patient and on any of the shared equipment between patients. But the one that I think has had the most impact on preventing infections is the alcohol-based hand rub. So I remember years and years ago at the beginning of my nursing career where the only way to do hand hygiene was soap and water. And it was really time consuming and inconvenient to have to go find a sink. My hands were always red and raw. And I remember when the alcohol-based hand rubs were installed and how much easier life was. It was made it so I could be compliant with the hand hygiene at the appropriate times. And my hands weren't as red and raw. So between 1995 and 1998, the University of Geneva replaced soap and water with alcohol-based hand rubs, and this greatly improved their compliance among healthcare workers. And subsequently, it reduced their HAI rates by 50% and their cross-contamination or cross-transmission of MRSA by 70%. So it rapidly became the global model for hand hygiene implementation. And then in 2002, the CDC came out with their guidelines to support the use of alcohol-based hand rubs as the preferred hand hygiene method. So which method kills bacteria better, soap or alcohol-based hand rub? And we know that alcohol-based hand rub is really the gold standard of care for hand hygiene right now. So compared to soap and water, alcohol-based hand rub with the alcohol content between 60 and 80% is more effective at reducing bacterial counts on the hands. In addition, alcohol-based hand rub causes less skin irritation. It's quicker to do than soap and water, and it can be anywhere. It's more readily available throughout the facility. So Knowing all this, how do you know where to begin as you're creating your hand hygiene program? And I'm just going to be honest with you, it's not easy. But the way to start is to read the guidelines. So CDC has their 2002 guidelines. The World Health Organization came out with their guidelines in 2009. SHE, IDSA, and APIC have a joint guideline that first came out in 2014. They recently updated it for 2022. And all of these provide a very comprehensive explanation of anything, absolutely anything you want to know about hand hygiene, from skincare to products to fingernails to hand hygiene opportunities, what kind of audits to do. But one of the most important things that's in these, if you take the time to read through the whole thing, is they have implementation practices that can help you walk through what you need to put into your program. So out of the World Health Organization guidelines came several educational posters that we have used for the past almost 2 decades now that have been so beneficial. And it helps shape how we teach about hand hygiene. So the World Health Organization 5 moments, they're similar to the CDC guidelines, but when you look at the CDC guidelines, they're just task-oriented line listings. But when the World Health Organization came out with this, it just reframed them to make it easier for healthcare workers to identify when it's appropriate to do hand hygiene. And it also makes it easier to frame the moment around the purpose of the hand hygiene opportunity. So is it to protect the patient from the healthcare worker introducing bacteria to them, or is it to protect the healthcare worker and the environment from getting pathogens from the patient? You've probably also seen these posters. So these were created because as easy as it is to do hand hygiene with alcohol-based hand rub, there are certain techniques that need to be followed to be effective to kill the transient pathogens on our hands. So factors that really affect the adequacy of our hand hygiene technique include covering all surfaces of our hands and our fingers, making sure that we get the appropriate volume of product to apply, making sure that the duration of hand rub so that we get enough product that we can do the full 15 to 20 seconds with the hand rub. And then it's also important to point out as we're doing our training that often people don't do their thumbs. They forget their thumbs and they don't really get underneath their fingernails. So stressing that when we're teaching how the proper techniques is important. And then for hand washing, the key to that is really to make sure that your hands are wet before you put your soap on it to make sure that it works appropriately. And then scrub for the appropriate amount of time, and then use the paper towels to turn off the faucet after you've dried your hands so you're not recontaminating your hands. And a lot of facilities have used Glow Germ to show people that if they're cleaning their hands appropriately. And again, people love this exercise. And I think it's twofold. Number one, if they do it correctly and they come back and there's no Glow Germ on their hands, it really gives them a sense of accomplishment and they feel good about themselves. On the flip side, if they miss places, again, you get that shock factor, that ick factor about the areas that they miss. And then the next time that they're doing hand hygiene, they're really thinking about, oh, I probably still have, stuff on my thumb or on my the heel of my hand, and I need to focus on that. So the World Health Organization went a step further in 2009 when they published their guidelines, and they put out a guide to implementation. And this was developed to assist healthcare facilities on how to actually implement the improvements in hand hygiene in accordance with the guidelines that they put out. And the guide has 5 key components for ensuring a robust hand hygiene program. And as I was reviewing them, I tried to see, is there just one component that we could do that's going to be more important? And if we do this, everything's going to be great. However, I realized that each one of these is needed to have a successful program. And this has been validated again by other studies that have shown that using a multimodal promotion strategies are a lot more effective than doing single interventions in changing the healthcare workers' behavior. And this is really due to the complex and multifactorial determinants of hand hygiene compliance within each individual facility. So ultimately, what does this mean? It means that to be effective, you can't just have an auditing program without doing education and training. Or you can't just make sure that the product is available where it needs to be without performing audits and training. So you need all of these components to really be effective in doing hand hygiene. So when we look at the first component, it's system change. And what this represents is the necessary actions that we have to take to ensure the availability of hand hygiene supplies at the point of care, especially our alcohol-based hand rubs. So this means that assessment of all areas should be done, and we need to make sure that the dispensers are near the point of care. So near the patient's bed, or at the very least at the entrance to the patient's room. So if you only have dispensers outside of the patient's room, there's really no way in the world that staff are going to be able to be compliant with all the expectations of when they're supposed to do hand hygiene. For the in-room dispensers, they should be easily accessible and visible, so preferably within the line of sight. And then this is going to give a prompt or a reminder to staff and visitors to do hand hygiene. We also need to make sure that the access to the dispensers is not hindered by placing portable equipment too close to or in front of the wall-mounted dispensers. So if they're not easy to get to or they have to move around something, people just aren't going to use them. And then there should be a way that we can do periodic audits of the dispensers throughout the year to make sure that they're continuing to work and give the appropriate volume of the hand sanitizer. The next component is training and education of healthcare workers. And this aims to improve healthcare worker knowledge. So everybody knows that they need to do hand hygiene. So don't ever tell people you need to wash your hands, because everybody knows that it's important and they have to do it. What we need to work on is how to identify when and how to clean their hands using the recommended techniques. So we need to make sure that the education touches all staff and that it's delivered in several different formats, because what resonates with one person may not work for another person. So lots of different avenues to get the education out. So there was a systematic review that was published in 2019 that emphasized that hand hygiene adherence results were higher among nurses when they used an audio-visual media rather than just your traditional methods of teaching. So another important component is evaluation and feedback. So auditing is important, don't get me wrong, we need to audit, but more important than that is we need to make sure that it's meaningful and that it really gets the information that we need to improve the processes and make it easier for the frontline. So we need to have avenues where we can have open and honest discussions about hand hygiene and what the barriers are. And this could be through a hand hygiene team, so either at the unit level or the hospital level, or it could be if you have just-in-time coaches that are out watching people do hand hygiene, and if they don't, to have that conversation with them to find out what barriers there were to being able to do that. Or maybe you have suggestion boxes, or maybe there's a QR code where somebody can scan that and send, a suggestion or something to an email. It's also important to have a venue to get the information back to the frontline staff. So this can be through graphs and charts, and it can be shared on the unit level, the department level, the leadership meetings, just so everybody knows what's happening with hand hygiene. And the information needs to contain not only the compliance, and it can be broken up however you want, if you want to break it up by unit or break it up by, was it a physician or a nurse or respiratory? But I think more important than that, we need to report out the barriers that are being identified. So other people can be thinking about what they should be looking at on their unit. So say 50% of people weren't compliant with hand hygiene, and of those, 20% of the time it was because the dispenser was always empty. So then that gives us an action to talk to whoever's filling these to make sure that we have a process in place to monitor that there's always hand sanitizer in the dispensers. Another way to give immediate feedback, which this is a kind of a fun one, is through giving stickers. So if you're doing hand hygiene observations and you notice somebody does it appropriately at the right time, they get a sticker. And then maybe after they collect 5 or 6 stickers, then they get a meal ticket or a gift card or something, just to help promote the positive people doing hand hygiene. When I worked at a smaller facility, when we did hand hygiene, I had the observer send me the names of the staff that they were auditing. And then I worked with marketing to create an email card to either thank them for doing hand hygiene appropriately or to let them know that they had missed an opportunity. And people really enjoyed that. And then again, if they got so many emails of the positive and they turned those into their manager, then they were able to get a meal card. So putting up posters and screensavers or signs in the workplace to help trigger hand hygiene is a good way to do it too. So you can really get creative with this. At one of my previous hospitals, we had staff submit hand hygiene posters that we used as screensavers. And so we were constantly changing those to keep it fresh on people's mind. And then plus people took pride in the fact that their artwork or whatever, their idea was being portrayed throughout the whole hospital. I've talked to other facilities that had competitions with staff creating hand hygiene videos, and then they take those and they post them on the internet site. And then there's winners of who made the best video. These are just some examples of campaigns that have happened over the years through CDC and the World Health Organization and posters that they've created that people have been able to use in their facilities. And the important thing to remember when you're doing posters or anything like that, to have a positive spin on it, to get people excited about doing hand hygiene. And then finally, the fifth component is having a strong culture. This is so important to really have a successful hand hygiene program. And I'm going to talk about this a lot later in our presentation, because it is so important to making sure that you're successful. So with the implementation document, within the World Health Organization implementation docket, there's a lot of templates and resources that they put in there to help guide you through each of the components. So as you're working through each of those components, there's worksheets that you can do and things to think about. And as you do them and walk through it, it really helps to create your action plan for how you're going to roll out your hand hygiene program. And this is just another example of how you can create it in a table. So it has the components, it has the elements under each component, and then what you've done or what you need to do to accomplish those. So the SHEA, IDSA, and APIC came out with their practice guidelines. Again, the first ones came out in 2014, and they were recently updated in 2022. And the purpose of this document is to highlight practical recommendations to assist acute care hospitals in helping them prioritize and implement strategies to prevent healthcare associated infections through hand hygiene. And so one of the benefits of this document is that the recommendations are broken up into essential practices that everybody should be implementing. And then it also has a section about additional approaches if you have an outbreak on a unit. And then some approaches that should not be considered because they've been proven to not be efficacious. And then finally, there's a little bit down there about some unresolved issues around hand hygiene. And similar to the World Health Organization, they have in their document some implementation strategies. And I'm not going to dive too much into these. They're very similar to the ones that were in the World Health Organization one, but they're phrased a little bit different. So it may resonate with you a little bit better, the SHEA ones over the World Health. But if you go through the document and read through it, it comes up with questions and what these were just the main topics. And then underneath those, it really breaks it down into the nitty gritty of what you have to answer or what you need to do to accomplish these. So the four options, the four elements are to engage. So really your multidisciplinary team, who needs to be on it? How do you create this? How do you encourage the units to have the peers to be doing hand hygiene to get everybody else on board with it? How do you identify barriers, but also facilitators, and then make sure that that is throughout your institution? And then a little bit about how do you pull in patients to take an active role in reminding healthcare practitioners to perform hand hygiene. And then you go on to educate. So making sure that staff are knowledgeable on this skill. Again, using the interactive methods about technique for hand sanitizing, using short, frequent educational interventions that continually build on knowledge. So it's not a one and done. You can't just roll out education once and think that it's going to last forever. You have to constantly be building on it. And then using principles of adult education to really encourage and participation, ongoing learning. And then execute. So similar to the World Health Organization, providing access to the supplies that you need, where you need them, so that they can work with the flow of the healthcare practitioner. Implementing your multimodal hand hygiene improvement program, and then focusing on targeted behavior change, which we'll talk about a little bit about that later too. And then evaluate. So measuring hand hygiene adherent performance, measurement. So what tool are you going to use, which we'll talk about a couple of those in a minute. And then how do you get the feedback to the frontline staff and the leaders, and then with the action plans to really improve adherence. Another great implementation guide is the APIC Guide to Hand Hygiene Programs for Infection Prevention. So the purpose of this guide is to provide an overview of hand hygiene programs and their key components. So it's targeted towards new IPs or non-IP colleagues who wish to understand how these multimodal strategies are applied as part of the hand hygiene program. But it can also be used by experienced IPs who want to just revisit their hand hygiene program and see if there's anything extra that they need to be adding. So it's a deliberate effort to summarize the state of the field with duplicating very valuable resources that are available. And the effort was to provide an overview of the evidence-based strategies for IP. They don't want to recreate the real, so it just is taking what was created by the World Health Organization and CDC with their guidelines and helping you figure out how to implement this effectively in your institution. And then finally, here's just some other useful documents to help you figure out how to implement a robust hand hygiene program in your institution. And these ones come from the Joint Commission. So the first one is Measuring Hand Hygiene Adherence, Overcoming the Challenges. So this was a monograph, and the goal of it was to identify promising practical techniques for measuring adherence to hand hygiene guidelines. And it provides a framework to help healthcare workers make necessary decisions about what, when, why, and how they're going to measure hand hygiene performance. But it also includes resources to help organizations select the measurement approaches that will best fit their needs. And it was developed using two primary sources of content. The first one, they took examples of methods and tools that other real-life facilities were using that they found effective, and they submitted them to this committee, and then they were able to disperse those throughout this monograph as examples of what this implementation means. And then the second source that they used is evidence-based guidelines and published literature. So the other useful document, which is more up to date or whatever, is the Hand Hygiene Targeted Solutions tool. And this provides the foundation and framework of an improvement method that, if it's implemented well, it's going to improve the organization's hand hygiene compliance rate and contribute substantially to its efforts to reduce HAIs. So the Hand Hygiene TST is an innovative web-based application that really guides healthcare organizations through a step-by-step process. And by step-by-step, I mean step-by-step. It lines out every task that you need to do. And by doing this, it helps you to accurately measure your organization's actual performance, and as well as how to identify the barriers of why people aren't doing hand hygiene. And then it'll direct you to proven solutions that are customized to address your particular barriers based on your unit or your hospital or your facility. And the way that the Hand Hygiene TST works is it uses a robust process improvement methodology in its design and structure. And this is a fact-based, systematic, and data-driven problem-solving approach. And what it does is it just pulls in a lot of concepts from the Lean Six Sigma and formal change management methodologies. So it's really a robust program. And the best practices, so what it's going to help you do is select and build your team, leadership support, who needs to be part of it, why is it important, how do you convince them to be part of all of this. Selecting your units. So are you going to start on just a few units to trial it out and then broaden it over time? How do you train your data collectors, which is huge? And then collecting the data. How do you collect the right data to make the changes that you need? And then how to implement solutions appropriately based on what you're finding. And one of my previous facilities, I was from the beginning to the end of the rollout of the TST best practices. And it was a lot of work, but it was exciting. And it really helped to change the safety culture at our facility because everybody was speaking the same language. Everybody was on the same team. Everybody was pitching in. And we really did see huge improvements in our hand hygiene rates. So I would highly recommend looking into the TST if you get the support and you're needing to start from scratch. So after you've identified your team, you've assessed your facility to make sure you have the right supplies in the right places, you've created your education for your staff, you need to identify how you're going to monitor hand hygiene compliance to ensure that you are successful in your program. So by doing this, you need to start by answering certain questions. So why is your healthcare facility measuring hand hygiene adherence? What is your hand hygiene adherence goal? Is it 100% of the time that people walk into the room that they're going to do hand hygiene? Or is it, are you looking at, are they doing the right technique? Are you measuring the 5 moments of hand hygiene? You really need to figure out what your hospital, what our facility needs to look at. How will the measurements be performed? Is it going to be by an electronic monitoring system? Is it going to be direct observation? Who's going to be doing them? And we'll talk a little bit more about what questions do you need to ask for that? How is the data going to be shared? So once you get that information, how are you going to break it up? Is it going to be by each person, nurses, physicians, respiratory therapists? Is it going to be by the unit? Is it going to be house-wide? How are you going to get it to leadership? Who in the unit needs to receive it? How are we going to drill it all the way down to make sure that the frontline staff is aware of what their data is? And then who's accountable for the data? So who is the repository for all of the observations, making sure that the graphs and the charts are done and sent out? That's one aspect of it. But the other aspect is who on the frontline staff or the managers is going to be looking at this data, and if they're not meeting their targets, creating an action plan and working through all of this. Is it going to be the managers? Is there a team on the unit that's going to be doing this? Is it house-wide that they're going to be looking at this? So these are all questions that you need to ask within your hand hygiene team or your leadership team so that you know moving forward that you're monitoring the right thing. So some reasons for measuring hand hygiene adherence. Are you doing it to reduce HAIs? Are you doing it just because of a regulatory requirement? Are you trying to make sure you're compliant with the Joint Commission, or if you're part of the Leapfrog facilities, are you doing it to meet those requirements? Is it to determine if performance requires improvement? So, we rolled out this hand hygiene program. Do we need to or not? What are our rates? Is it to compare performance to other organizations, or is it to inform improvement efforts? So again, we changed this process, and we really think that we got a good process in place to make it easy for people to do hand hygiene. You need to go back through and audit and make sure that you're getting the results that you wanted. So once you answer the questions about the what and why you want to measure hand hygiene adherence rates, you can move on to how are we actually going to do this? And this is harder than it seems. And this, I think so many people focus on the auditing process that they think that that's their hand hygiene program. And it's important to remember that the auditing is just a part of your overall hand hygiene program, but it's a huge piece of it as well. So we know that evaluation and feedback are part of the key performance indicators, and they're integral in the multimodal hand hygiene improvement strategy. However, there really is no perfect way or indicator for hand hygiene performance. So one way is to do the direct observation. So you go out and you directly observe a sample of hand hygiene opportunities. And to calculate the rate, it's the rate of adherence. You take the number of hand hygiene opportunities that were actually performed correctly, divide that by the number of hand hygiene opportunities. So if you're monitoring in and out, is each of those one? So the number of opportunities, and then you multiply that by 100, and that will give you your rate of hand hygiene adherence. So direct observation by a validated observer, as of right now, that's the gold standard for monitoring compliance. And the reason for this is because there's a lot of advantages to it. So it really enables you to estimate the adherence with all the 5 moments of hand hygiene, if that's what you're doing, or the in and out. So you can see how are we doing with that. More importantly, to me, I think it helps to identify the barriers of hand hygiene, because if you're sitting there watching and seeing somebody struggle because they got all this stuff in their hands that they can't do hand hygiene, or that they keep hitting the alcohol dispenser and there's no gel in there, those are only things that you're going to be able to identify if you're actually doing a direct observation. It also allows you to evaluate the hand hygiene techniques. So people are getting enough of the alcohol when they do the pump, or they just get just a little drop and then they're really just rubbing their dry hands. The only way you're going to know that is to be out there observing. And it's applicable in virtually all facilities, regardless of the level of resources, because it's just a person and your clipboard and you're watching. Some disadvantages, though, are lack of standardized methods for training observers. And this is important because if we're not all observing the right thing or the same thing the same way, then our data is not going to be strong and robust. We need to do periodic validation of observers for the accuracy. Oftentimes that this is not performed. It's like you're trained once and then we never talk to you again. We just want to get your data back. But not going back and validating it is a disadvantage. Inadequate sampling of hand hygiene opportunities. We know that there are thousands of hand hygiene opportunities that are happening on our units every day, every week, every month. So if we're only getting 10 observations, that is just a drop in the bucket. So we're not getting a good representation of hand hygiene opportunities. The Hawthorne effect, if IP's out there and we have our clipboard, people are going to know we're probably looking for hand hygiene, so they may be a little bit more compliant. That might skew the data. And observing all indications for hand hygiene is difficult in some settings. In the ICUs where you have the glass doors, it's easy to see what's happening in the rooms, but on units with the door, somebody goes in, they close the door, you don't really know what's happening in there. So it's more difficult to identify what happens. It's very time consuming. Anybody that's done hand hygiene observations knows how time consuming it is. And people think, oh, you just go out on the unit and you'll see all these people doing hand hygiene or all these opportunities. And that's not true. It depends on the unit that you're in. If it's an acute care unit and you're not there at shift change or when there's a lot going on, there might not be a lot of opportunities of people going in and out of rooms. So really being able to identify the right time to go when there's a lot of activity happening, so it's easier to get your observations. So some tips for optimizing direct observations. So when we need to consider certain things when we're utilizing direct observation people. So the methods for training observers is important. So will it be a computer-based module or an in-person? That's important. So it needs to address the scenarios that the observer will encounter and what the facility expectation is for compliance or non-compliance. So say you have somebody that's coming out of the patient's room, does hand hygiene, and then they're immediately going into another room that's down the hall, but they don't do hand hygiene into that room. So is it compliant coming out of that one and non-compliant going into the other one? Or are you going to consider it compliant for both because they haven't touched anything in between? That's all stuff that your hand hygiene team needs to talk through and identify what is compliant for you. And then more importantly, the observers need to be educated on the audit sheet that you're using for your facility. And you need to go line by line what each word means, what each section means, so that everybody is on the same page. And I learned this the hard way because I had an audit tool and I thought, well, this all makes sense. You know, I created this, it looks great. And then as I started getting information back, I'm like, well, why did you mark it like this? And so some people will read things and interpret them different than how you interpret them when you wrote them. So it's important to really go through each aspect of the audit tool so people understand and they're all answering it the right way. Again, trying to do periodic validation of the observers. We need to talk about the types of healthcare personnel who are going to be responsible for making the observations. So is it going to be their frontline staff? Is it managers? Is it only going to be IP and quality that are out there doing this? Can we get people from multiple different departments? So respiratory and dietary, or your social workers, you know, other people that are out on the units, can they help us with hand hygiene observations? Do we have champions on the unit that really feel passionate about hand hygiene that can help us maybe with some of the just-in-time training education? Whether or not the observers provide immediate feedback, or are they just there observing and getting, are they compliant or not? Or have we empowered them to have the conversation with the healthcare worker? What are the criteria? We talked about this for defining adherence. Talked about that a little bit. The length of observation sessions. So try to maybe limit it to less than 15 minutes to minimize some of that Hawthorne effect. And then making sure that you get all shifts. So if you're a 24/7 facility, that you get day, night, and weekend shift observations of it as well. So you can use the answers to the questions that we discussed to help you create or identify which auditing tool you'd like to use. So they can be as detailed or as basic as you need them to be. The most important thing is that it's based on the goals of your facility and that you get the information that you need to make the changes in your facility. So as you can see, the TST audit tool, it's very comprehensive. It's the one on the top left there. And it's really built to identify the compliance rate as well as the barriers for non-compliance. And so there's a very robust audit tool that gets you so much information, but really helps you be able to drive change on the individual unit level and the facility level. The World Health Organization, which is the orange one there, is designed to capture the 5 moments of hand hygiene. Or it can be as basic as a simple line listing. But again, the most important thing is it gets you the right information to accomplish the goals identified in your plan. So knowing how cumbersome and time-consuming the paper audits are, several companies have developed the hand hygiene observation apps. And at a minimum, these apps need to be able to do the location of the unit where the hand hygiene was observed, the role of the person who is observed, so is it a nurse or the doctor, one or more hand hygiene indications. So what was the reason? Was it in and out, or was it the 5 moments? As well as the type of hand hygiene action performed. So was it soap and water, the hand gel, or was it mist? And although there's not a perfect method or a perfect app yet, all of these can help reduce some of the error with doing the paper charts. So if you are looking at a hand hygiene observation app, there's 3 essential elements. How easy is it to put the observation? How many clicks does it take to really get that observation in? What's the data elements that your organization is looking at? So if you're doing the 5 moments, but this only does in and out, it's probably not going to work for you. And then how do you get the data out? And how easy is it to create the graphs and charts that you need to tell your story? How many observations do you need to do? Again, this is dependent on your facility. What are your resources? What are you trying to accomplish? If you look at the World Health Organization as well as Leapfrog, they recommend trying to do 200 observations per unit per month. My thing is, I would much rather have good quality audits that are telling me what's happening at the bedside and what's happening with the flow and what the barriers are, over a whole bunch of audits that somebody just went through and said, yes, everybody was compliant. Automated hand hygiene monitoring systems. So these are new, newer over the past couple of decades or whatever, and probably the last decade. The thing to remember with these is if the healthcare facility is going to use them, they should be implemented as part of the multidisciplinary hand hygiene improvement program. So just installing one of these alone without complementary strategies really is unlikely to result in significant improvements in your hand hygiene. So what else do you need? You need to make sure that you get support from hospital leaders, that there's enough staff to maintain the systems, but also to tell the story that we're bringing these in to promote safer patient care, not as a punitive thing. We need to give managers and the frontline staff frequent feedback from these to make sure that they're working appropriately and we're capturing the right information. We need to set reasonable goals. If we're monitoring, 150,000 observations, 100% compliant may not work. We also need to require the nurse managers or champions to take accountability meetings so that they know how to have conversations. If people are only 30% compliant, how do you have that conversation with that staff member without offending them or making them mad or feeling punitive? And then we need to employ quality improvement initiatives. So despite the advantages of the automated hand hygiene systems, hospitals are a little slow to adopt these. And some of the reasons are suboptimal accuracy of some of the systems. And really that goes back to the early ones, the cost of the implementation and the maintenance, concerns that how accurate are these and how is the data going to be used, the need for doing complementary strategies. So if we're spending all this money to implement this, but we still have to do all this other stuff, is it worth it? And there's relatively limited evidence right now demonstrating that there's sustained improvement efforts in sustained improvement in hand hygiene performance, as well as reducing HAIs. So we need a lot more robust data on that. But if you are thinking about implementing one of these, making sure that you're asking these questions up front. So what's being monitored? Is it just in and out? Can we get closer to the bed? Is it patients or it's employee specific, or is it anybody that goes in and out? How accurate is the data? Is it the sensors really picking up all the opportunities? How is the data reported? What graphs and charts can be created? What's the installation process? Do we have to put in new dispensers? Do we have to put holes in the wall? What's it going to take? And what's the training and services that are going to be provided by the manufacturer when you install this? A couple of ones that are out there. You got the automated group. This one is just used to measure a combined hand hygiene compliance rate for multiple individuals. So whoever comes in and out is counted, whether they're a visitor or they're a staff member. Benefits, it collects a whole bunch of data for you. It's 24/7, less personnel required than direct observations, takes away the bias. You can get real-time rates for your nursing unit. It's less intrusive than the badge. So a lot of good things about it. When we look at the automated badge system, so people wear a badge and then we can get down to the individual person. These been shown to collect 5,000 to 150,000 opportunities per unit per month. Again, they're 24/7, less personnel, not affected by the Hawthorne effect, can get real-time feedback to the individual level. Some of them will provide immediate auditory, visual, or vibratory feedback, so a reminder to do hand hygiene. So just looking at the pros and cons if you're going to implement these. But I know I just have just a few minutes left, so I just really want to touch base on barriers and mindset. So as we're doing barriers to hand hygiene, system level barriers, so the time pressure, inadequate staffing, I don't have time to do everything that I need. I can't find a sink that I need to use, or the alcohol dispenser at the places that I need it. Those are all system level barriers. And then there's provider level barriers. So deficits in the education. I don't know what's the best time to do hand hygiene, or I don't know the best technique to do it appropriately. So also the social environment, so can be positive or negative. Everybody is seen when there's a positive role model out there and everybody seems to follow them and do what they're doing. And so we need more of those to be champions on our units. Leadership buy-in. We need leaders to be talking at the meetings and as they're rounding to talk about hand hygiene, to really make it become part of the cultural norm on in your facility. Safety culture. This is huge. So the sum of what an organization is and does in the pursuit of safety. It's the product of the individuals as well as the groups, their beliefs, their values, their attitudes, their perceptions, all of this that plays in, and it determines the organization's commitment to quality and patient safety. And it's created when there's a shared commitment for promoting, encouraging safety promoting behaviors. So if everybody's talking hand hygiene, then everybody is on the same page, and it is going to increase your safety culture. So if you're focused on a safety culture, you don't change the task, you change your mindset. And what this means is we know that clinicians behave how they think they should, and they're influenced by each other rather than what's coming from up above. So we really need to make sure that our key players are on board with what we need. We know that frontline clinicians in complex adaptive systems accept new ideas based on their own logic, not those of upper echelons. So if I roll out this campaign, I have to make sure that the person that's going to be doing it, it makes sense to them. That all these times I want them to do hand hygiene. Does that make sense to me? Can I do this? And then they're going to be more likely to follow. And then those in the front line of care navigate change through their small part of the system. So they adjust to their local circumstances and respond to their own interests rather than the top down. So making sure that all of these initiatives are at the individual department or unit levels so we get buy-in from them. So we need to pay attention to how care is delivered at the bedside, what we talked about earlier, and walking through the different people and your tasks that you're doing, and how do you do it to make sure that your care is, that the supplies are readily available for you. All meaningful improvement is local, and it's centered on natural networks of clinicians and patients. So again, that unit level is really going to drive what gets done and what's accepted. We need to recognize that big interventions sometimes have little or no effect, and that some of these smaller initiatives can yield unanticipated outcomes. So we spent all this time to roll out this huge campaign, but at the unit, they identified that they just don't have the dispensers in the right place, and that's going to have more of an impact than the big rollout that we did from the system. And we need to appreciate the complexity of care systems and understand that change is always unpredictable. It's hard won, it takes time, it's very torturous, and it always needs to be tailored to the setting. So it's not a one and done. We always need to be changing it and seeing what we need to adapt to. So we need to use the right language. So frame the conversation for the audience you're presenting to. How you speak to leaders is going to be different than how you speak to the frontline staff. Make it an issue of the heart. So make it personal to them. And then know the other side's position. So identify and map out how hand hygiene should be done in their job description and duties. What a nurse opportunities for the nurse are going to be different than a social worker or an EVS staff or a dietary. So really working with each of those departments to identify when they need to do hand hygiene. And then again, top level buy-in. So everything else is futile if your leaders are not on board, and everybody at every level is talking about it. Staff need to know that hand hygiene is a top priority of the organization. And then I'll probably finish with this one because I think we're at time. But hand hygiene is a habit. So our ultimate goal is let's make hand hygiene a habit, which means that it should be a spontaneous behavior involving non-thoughtful behavior, behavioral responses shaped by perceptions of the context of the environment. So as I'm walking in the room, it's just a no-brainer that I'm going to hit that dispenser as I walk in. We need to establish strong automatic associations between performance of the behavior and the contextual clues. So again, as I'm doing my process, there should be different things in there that are triggering me to do hand hygiene. And then after all that, it should be a natural part of the routine. So if I'm doing central line care, that I know that there's certain times that I do hand hygiene and I don't even have to think about it because it is so intuitive to me. So I think you guys got the slides, but the rest of them kind of talk through factors that influence compliance that are really kind of self-explanatory. I think it's important to think about those as you're sending out a message or creating education or having conversations, that you need to take in all of these different things that people are thinking to really help them be compliant. And then my sources are at the end. Appreciate the opportunity to present this.
Absolutely. And this has been a really informative presentation. And how you started the presentation, this is such a complex topic. And so we really do appreciate your time today, sharing your knowledge about the importance of hand hygiene programs. There were a couple of questions that were submitted in the Q&A, and I know we're at the top of the hour. So Mary, if you're okay, if we send you those questions and if you're able to answer them, we'll be able to add those to the email blast that goes out to all registered participants, which will include a recording of this presentation, the slides, and the evaluation. So I want to thank our participants again for attending, and we look forward to seeing you at our next webinar on April 11th. Mary, I see a lot of comments in the chat thanking you and just saying how informative this presentation was. So thank you again.
Thank you.